Welcome back. The Minister of Health, Dr. Zweli Mkhize, has been up and about in Gauteng this morning. And earlier he was at the Charlotte Makhura Hospital in Johannesburg, and he was meant to make his way to Soweto. Currently he's addressing the media. Let's take a listen.
Where there were two groups on the one side and he had to stand in the middle. And we really remember that he made a huge contribution that helped KwaZulu-Natal to take the direction that he took. So we want to say to his family, we share in their grief. And City Hambagahle Nyanda Epash. Secondly, I was pleased, Premier, that we were able to visit Charlotte Makhura Hospital. It's part of the celebration to honor the memories of Charlotte Makhura, who would have been by today 150 years had she lived. But she was one of those very courageous fighters for freedom who brought in onto the table the issue not only of the liberation of black people in general, but she was the one who raised the issue of the equality of male and female, and therefore raised the issue of women emancipation immediately onto the fore when she was actually standing on her own. And she continued to be the limelight who was able to lead from the front, showing concern for our people and going all out to do everything to serve our community. She, of course, was the first graduate in the Wilberforce University in Ohio in 1903, where she graduated in a Bachelor of Science degree. And all of us who have been through the science stream know how difficult it has been to manage to get our people into that stream. So she was amongst those first top intellectuals that helped to lead our struggle during the time where we were to move from the a struggle led by the resistance of our traditional leaders. And of course, we started having the modern, contemporary liberation, freedom fighters of our modern days. So she's a real, a stalwart of our struggle and a hero that is really worth commemorating. Let me then come back to the issue of today and start by apologizing to the nation for the difficulty that was caused over the past 2 or 3 weeks. It's been difficult to get new information, and that was mainly because there was no new information. This is largely because of the intricacies of having to negotiate, where you spend so many days trying to get new information and nothing was coming forth. And of course also the challenges of having to deal with the non-disclosure agreements which were imposed upon the government as we're negotiating the procurement of vaccine with the manufacturers. So for a while you could actually ask a question, there would be no answer because there was no new information. It's a very nebulous process which really has made it difficult for South Africans to follow what has been happening over that period. We have never doubted our obligation to account as public officers. However, we found ourselves in such invidious position where we were to choose between honoring the terms of these non-disclosure agreements or disclosing the details of the deal to the public when it was actually not concrete. But also doing so would risk us getting those vaccines in an environment where the whole world is scrambling for vaccines. For any one delay or 1 day's delay, you actually fall back on the queue, and therefore we have to try to push and hold your position on the queue so that ultimately we can get the matter closed. It's not a very easy matter, nevertheless, we do believe that whilst that was going on, people were getting anxious about needing new information, but unfortunately there was no new information during that period. We chose to rather secure the stock by cooperating with the manufacturers and therefore comply with the processes of negotiation. And as we know that this caused anxiety, we now release from that those NDAs and are in a position to disclose some of those details. So we want to thank South Africans for always engaging us. Nevertheless, this demonstrates a high demand for vaccine, which for us is very important as we seek to achieve population immunity. The fact that you've heard from the previous old age home, all the old people were asking for when do we get our vaccines. Everywhere you go, that for me is a positive sign, because there was a point at which people were worried that there would be actually, no interest in or fear of the vaccine. Clearly, we are not there. We are at a point where the demand for the vaccine is going to be very, very high. In fact, if there is any issue that I think about every day, is the issue of two things that are always a matter of concern to me. On the one side is the fact that we are reliant on the flow of vaccines coming from manufacturers at their own pace, and you can't do anything to force them to move faster. And therefore, that may be one area that might be a limitation in the way we run our vaccination program. The other side, that's always a matter that keeps me awake at night, is the level of demand for the vaccines. That will always be higher than the vaccines that are available. How to keep the balance between those two issues is going to be what this whole vaccination rollout is going to be about. We will therefore require support from the public, from all the leaders, and from the media, from everybody, so that we are able to send one message to everyone, so as to ensure that we can align the available vaccines to the demand that is out there in the community. So I also wish to address the highly valued health workers, and now again I want to say to the health workers, on the original plan, when we were announcing in January, we were actually anticipating that we were going to rapidly roll out the 1.5 million vaccines, which was AstraZeneca, to all the health workers. And at this point, as we can see, we have not really managed to get to that level. And I want to say that that's been because of the challenge that we've had to face. On the 1st of February, we had actually received 1 million of the 1.5 million doses of AstraZeneca vaccine. These doses had been enough to administer the first dose of vaccine to all the health workers. Actually, although we hadn't announced it, we had another ready dose, total of 2 million doses, which were being finalized, coming from the donation that we had received. So there was going to be another 2 million that would have come in immediately after that, and everything was actually ready for it. We hadn't announced it because we're just finalizing that. Then, of course, unfortunately, the variant frustrated our noble goals, and we had to make contingency plan. I think all of us recall that we came together in one evening, Professor Madi, Professor Abdul Karim, Salim Abdul Karim, Professor Glenda Gray, and a few others, where we sat together, and then we announced the fact that there were the results of the AstraZeneca, the Novavax, and the Johnson & Johnson results had been released. Now, when we did all the ordering of these vaccines, we did so on the basis of the scientific evidence that was emerging to suggest that AstraZeneca would be one of our best doses around. And so we anticipated that the situation in South Africa would be no different. And of course, then we discovered towards the end of the year, from October, there was a new variant in South Africa that behaved totally differently to what the other variants had been doing in the different countries. So at the time when we were going through this particular announcement, where Professor Pollard was the chief investigator, the top scientist in charge of the entire issue around AstraZeneca, which is the Covishield Oxford vaccine, and they indicated to us that in the UK, the efficacy of the AstraZeneca vaccine was good in Brazil, including the situation that they had their variant. Unfortunately, in South Africa, the results from the study, which was led by Professor Madi, indicated that because of our new variant, we actually had a different efficacy, which was much, much lower than what was experienced in the whole world. And of course, we had then a decision to take that it would even probably be an ethically questionable decision to go on and administer AstraZeneca in a setting where there was evidence that it was going to be less successful, when in fact in the same setting we already had an announcement that was showing that the Johnson & Johnson vaccine was going to be effective. Even the subsequent analysis that have been done have indicated that some of the other vaccines candidates were actually going to be performing in a reasonably better manner. So we wouldn't therefore take our health workers and give them this particular vaccine when we know that by last month, by February, 99% of the COVID-19 infections were actually due to the predominant 501YV2 variant, which was behaving in a manner that was causing concern, not just in South Africa, but throughout the world. So I have heard some people saying that we should have used those vaccines. We actually had clear scientific evidence and support that we should actually avoid using that. Instead, we should actually move to get different vaccines. That was the basis on which we then moved to get the vaccines which were available from the Johnson & Johnson manufacturer. Excuse me. And those, because they were available and they were similar to the ones that are going to be that we're expecting, all that we needed was to register it, register the process in the form of a study, which is now what we call the Sisonke Protocol, and we believe, therefore, that it was an important way to bridge the gap to actually start our health workers into the vaccination program. So the protection of health workers is absolutely paramount. And I want to say to our health workers, we value you. We thank you for the work that you have done. We thank you for your patience as we wait for all the vaccines to be available. We will continue to prioritize the protection of you as health workers so that before we go all out to roll out, we will have made sure that all the health workers are vaccinated. And we continue to appreciate the fact that you as health workers fight every day to ensure that we can accelerate towards our targets of ensuring complete phase 1 and also making sure that we are able to get our healthy health workers being in the forefront again to face whatever comes of the COVID-19 situation. We then also need to indicate to, again, fellow South Africans, there was a huge concerns about whether these vaccines were now going to be wasted. And of course, we want to indicate that all of the AstraZeneca vaccines have been salvaged. 1 million doses that we had received, we have sold them to the African Union platform, and they've been distributed to many African countries who have been able now to have access to these vaccines. And the difference between us and some of these countries is the fact that they actually don't have the same variant as what we've got, and therefore they also don't have evidence in their country that the AstraZeneca would be a problem. So we go by, in those countries, we go by the WHO guidelines that said it can be used even if there are other variants in other countries. So we believe that there's nothing that has gone on very well. Today as well, I'm pleased to announce that Treasury has confirmed that the Serum Institute of India has fully refunded us for the remaining 500,000 doses that had not been delivered to South Africa, and the money is now already in our bank account. I want to clarify this quite clearly, because this now closes the matter of the AstraZeneca vaccine, and we close it without incurring fruitless and wasteful expenditure, and will continue to engage AstraZeneca as they pursue their research and development for the next generation of vaccine, and we hopefully can deal with them at a point when they are able to show efficacy against the 501YV2 variant and other lineages. And AstraZeneca as a company, we work very well with them. There's a whole lot of other areas where we cooperate with them, and they do work with the department. And so in this case, it's really we're just dealing with the results of the findings that had come to be known in South Africa as the efficacy studies on the 501YV2. We are therefore pleased that we have put this and most and other stages of the deal making with Pfizer and Johnson & Johnson behind us, and that we have now secured a combined 51 million doses of vaccine in the agreements that have been signed. 31 million from Johnson & Johnson, which is a one-dose vaccine, and then 20 million from Pfizer, which is two-dose vaccine. We have also got a letter that's indicated that there will be some vaccines coming from the COVAX facility. At the moment, they've only spoken about 1.25 million vaccines. And so this means now we can now move ahead with confidence as we finalize our plans for our mass rollout campaign, which is officially due to begin at the conclusion of phase 1 on 17 May. And you recall we've said at the beginning there are 3 phases. The first phase must take us 3 months, and so we started on the 17th of February. So 3 months ends on the 17th of May. We wanted to move faster than that. Of course, if we didn't have this debacle with the AstraZeneca vaccines, we would have really been able to move a bit faster, as we had indicated to the public that we wanted to move faster than those. So the 17th of May marks the end of phase 1 by right, and therefore we will then be starting phase 2 on the 17th of May, going on to the 17th of October. We said the second phase should take us 6 months, and therefore we're still sticking to that. Then, of course, from the 17th of October going forward, that will be starting the last phase. On the 6th of April, we announced that we expected a final tranche of the 200,000 Sisonke protocol from Johnson & Johnson this weekend. We've just been informed as well that because of the difficulty in getting the flights coming to South Africa, this will actually land probably Monday. So we will be then at that point have concluded the 200,000 doses that are associated with the Johnson & Johnson vaccine, the Sisonke protocol. So with those, we would have done 500,000 vaccinations on our health workers, which are one-off dose. That means, therefore, that the next lot will be coming from the manufacturing belt. It will be going straight for the a full implementation wherein there will be no study associated. Now, with this delay, of course, we would have liked to get these vaccines quite faster than what has happened. We did indicate that because they're being recalled from different countries, needing authorization from the releasing countries and also relabeling to bring them here, this is really why it has taken the way it has taken to bring us to where we are. However, all of this does not derail us from meeting our targets. We must also continue to encourage and commend our South African Medical Research Council, led by Professor Glenda Gray and their team, along with the whole department from the Director General and other members of the department leadership and the workforce that has ensured that we've got this success of this seminal initiative. Pursuant on our targets of vaccinating all healthcare workers by the end of phase 1, to honouring the schedule we have committed to for phase 2 and phase 3, we are therefore pleased to announce that the Johnson & Johnson have confirmed that we will be receiving 1,099,200 doses sometime this month. In fact, the exact date of delivery is currently awaiting the quality assurance processes, of which the documentation has been submitted to the authorities already on the 7th of April. So they have said they are releasing these documents. I'm sure we all recall that President Ramaphosa went into Aspen in Gqeberha and made sure, and we actually saw the batch that will be coming to South Africa while it was being manufactured. So we know for a fact. This was done to ensure that the process then can be fast-tracked. You recall when we spoke about the AstraZeneca, we spoke about the whole 14-day period of waiting. This process is going to shorten that a little bit, and so we still have to go through the quality assurance. But because everything is happening in South Africa, they have already started to send the vaccines for the quality assurance test, which was going to delay the AstraZeneca for about 14 days. And as such, we expect that Johnson & Johnson will be in a position to deliver this batch around 22nd to 24th of April, and this we believe that it will help us by then to be able to deal with the issue. The month, therefore, will not end before we roll out these market doses, which will be now beyond the Sisonke protocol, which was causing a bit of confusion to people whether this is real rollout or not. And of course it was a real rollout. We just needed to start with the health workers and the study attached to it. So these doses will be delivered from the Aspen plant in Gqeberha. And the advantage of this is that, as I've said, they shortened the dispatch from the plant and the delivery to the vaccination centers. I'd like to emphasize also that the market product is exactly the same as the protocol product, save for just the differences in the vial sizes and concentration of the mixture, which has not affected the actual dose of the active ingredient. So it doesn't really make any difference. It's just a packaging. It also gives me pleasure to indicate that Johnson & Johnson has expressed its intent to deliver a subsequent batch of 900,000 doses in May and 900,000 doses in June. And we expect the date of the exact volume to be firmed up in the next week or two. And as you now understand, the manufacturers are very wary of giving us a firm date because they say they don't want to be seen to be under-delivering. However, this batch may be coming from Belgium. The last batches might be coming from Belgium. Although this does increase the time from dispatch to site of delivery by a few days, we will not feel the impact of this. It will already be rolling with the vaccinations at that stage. And this issue of getting vaccines coming from Belgium was because we went through quite a rigorous debate with Johnson & Johnson, and it was clear, therefore, that if there is any delay that they foresee in the Aspen delivery schedule, then they will actually mobilize from other parts of the world to make sure that South Africa does not fall behind, and that they've insisted that they'll be able to honor that particular undertaking. Coming to the Pfizer, as we announced on the 6th of April, the payment processes are underway upon the conclusion of Pfizer. Upon the conclusion, Pfizer will then be in a position to break down their current quarterly commitment to a final schedule. With a committed date of delivery of the first batch, we therefore expect to receive the supply schedule early next week, the supply schedule next week. So it's the details of how they'll be delivering that's going to come next week. It's not yet the vaccines. Then we expect that within 14 days we should then be able to get the delivery once they've confirmed the funds have been received from that. I didn't even realize, you can just be delayed in the payment process. You need this pro forma, it must be in dollars. No, they've sent it in dollars, must go back, convert it into rands. All right, it's been converted, but which date of the currency exchange should they use and all of that kind of thing. So it just takes a bit of delay, but when I say the payment process, I'm talking about all of that is being concluded. So in the same way, we undertook an implementation study with Johnson & Johnson. We will also be doing an implementation post-market surveillance, which is the same thing as implementation study, amongst a limited cohort of healthcare workers. Now, we can never overstate how important these types of studies are. But allow me to clarify again that these studies do not test the efficacy of the vaccine, but rather gives us information on the broader impact of mass vaccination. The vaccines are the same. In fact, these doses that we'll use from Pfizer were not brought here for research. They were brought for implementation. But we will take a certain number which we will then use for the study. We have found a lot of lessons from this vaccination on simple things that we have observed, and therefore we think it's important to have the same kind of lessons on the Pfizer, so that we know as we roll out what are the things that we need to be taking care of. So that will be done with Pfizer, and it is also a condition surprise given to Pfizer that there will be this kind of post-market survey, and we are very happy with that, and we'll be working with that team to finalize all of that. So indeed, we are very excited that we are now almost well out of the woods in the procurement of the Pfizer and Johnson & Johnson vaccine. It is for this reason that we are visiting provinces to assess their readiness to roll out the vaccine, beginning here in Gauteng. And I'm sure you're aware that the Interministerial Committee has already been sending ministers to also go and do a similar kind of visits in different parts of the country, that the MECs and the premiers have also been doing the same kind of work, visiting different parts of the country. We know that there's been a great deal of hard work that has gone into the preparations for the mass rollout campaign, drawing lessons from the Sisonke protocol, as I've indicated. As government that values the evidence-based medicine, we have carefully looked at some of the initial key findings of the protocol, embarked on international benchmarking exercises, and undertaken some critical analysis of the impact of mass vaccination. And I'm glad that we were able to start with that, because it's really opened up a number of gaps that we need to close, which would have really been more difficult if we had just rolled everything out at that time. It's really been a kind of dry run, which has been welcome. As such, there are some of the key findings that necessitated the revisions of our rollout plan. The plan, as we had it at the time, and I was quite interested that the CEO of Charlotte Makhura says to us, we had one plan on the table, but what is being implemented is a different plan to what we had done. That is because of what happens when you get onto the coalface and things. You have to now start adjusting certain things. So we have seen a number of areas that require that we must begin to adjust this rollout plan. We will then be going through consultative process on this in the next day and few days to come. The first of these is that evidence shows that age is the most important factor in determining adverse outcome, such as death, hospitalization, and or moderate or to severe illness. Age alone as a factor surpasses comorbidities, occupational exposure, or potential exposure from living in a congregate setting. In other words, whatever you find, whether there are comorbidities, frontline workers, everything, what determines how many people end up with severe, moderate, severe diseases and hospitalization and ICU and death is age. The highest numbers of people are affected are above 60, and then of course, as you go further down, from 40 years upwards, which therefore means now, as we go into implement, we must take this into account. During the Sisonke protocol, we found that every time a criteria is introduced to stratify population at risk, this compounded the complications of the rollout of vaccines. We lose time, efficiency, and worse of all, the ability to capture the vulnerable population. We also render the system vulnerable to fraud, such as queue jumping. And then, of course, we get criticized when people get to overwhelm a setting, a vaccination site. Then, of course, government is criticized. Why is that happening? But, these are the things that are part of the challenges that we've had to manage. Having said that, we will adopt a flexible and practical approach which is going to take into account the age-based stratification to ensure that we ultimately net the most vulnerable as quickly as possible. And remember what we're trying to do. We want to protect those health services, we want to protect those who will end up in the hospitals first, so that they need to be safe early enough so that they don't have to land up in the hospitals. Then whoever lands in hospital, we can manage that situation. We have seen in the last wave how the first wave in June, July was actually much lower than what we'd seen in the second wave. And so the focus is to be able to block the way towards hospital by reducing the number of those who tend to be vulnerable that must go there. So we're now going to adapt it with that kind of flexibility in mind. We also had to reassess the kind of sites that actually make sense for the lived experience of our people and change some of the criteria for a site to be deemed fit for purpose in various scenarios. So as such, the master facility list has been created as a platform that allows for registration of potential site for critical analysis of the suitability of a registered site according to the needs of the areas that are going to be served. The provinces have identified thousands of sites which are now undergoing a process of verification, and we will announce those last week. Once all of this is tightened up, there will be a revision on the numbers of sites which we will be coming through to the public with. In the same way that we announced the activated quarantine site, we'll also be announcing vaccination sites that are incrementally activated. And why incrementally activated? We've also now found out that you can have a commitment to get 500,000 vaccines to be delivered. But if you plan on the basis that you're going to start at 500,000, you realize later that in fact it slowly comes. It doesn't come in a big bang, and therefore you now are going to activate sites, sequentially instead of all of them being activated at the same time. Finally, there were some other key learnings with regards to the electronic vaccination data system that require refinement, a robust outreach program and a support call center to ensure that we minimize on-site registration, which can be time-consuming and frustrate the allocation of vaccines across the country. We'll announce this when the EVDS system is ready to accept citizens that will qualify for phase 2, and will make timeless calls for the relevant population groups to register as the program progresses. We also embark on an extensive outreach program to assist citizens who may have challenges registering on the system. Even now, as we're going through in Charlotte Makhura, what you found was that the impact of the system is still felt. So you, for example, found that the health workers, they've been given the information, but nothing stops a large number of people to go to the site without vouchers. So that indicates that we will always have to deal with some of these teething problems, even at that level. We'd like to introduce this concept to the public so that when we announce the final details of the mass vaccination rollout, there's a common understanding that the revisions aim to enhance the efficiency of the program and to ensure the positive experience for citizens, minimize wastage and resources, and overall foster confidence in the program. We were asking the staff how much wastage happens here. And the wastage basically happens if you didn't align the delivery of the vaccine, because they've got to be kept at a certain temperature for a particular time with the numbers of people who must be vaccinated. So all of those issues need to be dealt with. So at the height of the vaccination, we would then be targeting that we can achieve up to approximately 250 to 270 citizens a day at our peak. But that won't happen in the first batch, which is the second quarter. It will happen towards the end of the third quarter and beginning of the fourth quarter, where the numbers will be quite high. Thus reaching population immunity within a period of about a year. There will be other provinces that we have seen that will actually spill over. When we announce the plan next week, we'll also indicate those. It's also very important to the government because ultimately the goal is to reclaim our economic and social lives as soon as possible. So it's important that we must get more people to get past this point. I'm happy, therefore, that we are here today. The Gauteng Department of Health is aligned with the National Department of Health, and all the preparations that they've shown us are progressing well. I believe that the province will be ready to render a high quality of service to our people. We'll be visiting other provinces in the next 2 to 3 weeks to assess the readiness for mass vaccination countrywide. In fact, the plan is that I will be in the Western Cape on Monday, and during the course of the week we'll probably have reached Limpopo. We'll also be looking at where else we should be going. But the fact that we're seeing what we're seeing in Gauteng is good alignment in terms of what the approach is, the strategies, the number of sites. They don't have sites, and the national has got different. National department has got different sites, and already the thinking, when you sit and get the briefing from the vaccinator on the ground, and get the briefing from the head of the institution, you can tell that everyone is now aligned, and that for me has been quite impressive. And I want to say thanks to the Premier, thanks to the MEC and the entire department for all the work. I've also said it's important that we've got the acting mayor, Masuga, and MMC Mkhize. Here they must also understand that when we deal with this, ultimately it's going to be a combination of all of us, government at national and provincial and at local level, non-governmental sector, as well as labor, business, and everyone. We're having lots of engagement with all of this. Tomorrow we will be having consultation. We've had quite a lot of discussion with business, and we're going to be meeting with labor tomorrow, so as a religious sector and civil society, to be able to close the loopholes so that we align ourselves. So what excites me most is that we're creating a legacy of unity in purpose between the state, the business, the labor, civil society, and each individual South African. Just as well as we are all in line, all line up together to vote every 5 years, we'll be lining up to receive our jabs, and we can all expect to receive the same quality of service no matter where we are allocated to go by EVDS system, and regardless of one's social standing, race, gender, or creed. If we all continue to work together as we have been done in the preparation for this mass vaccination campaign, I can assure you that we'll get the glorious glimpse of what future of healthcare in this country will look like. A system that will ensure access to quality health care for all South Africans, side by side, and blind to individual socio-economic circumstances. You have heard the Premier comment about the fact that there are 2 doses and there's 1 dose. What we are going to be doing, most of the Johnson & Johnson vaccines are going to be deployed in rural settings and in settings where there's mobile communities, which makes it difficult to manage the movement of people, so that one person gets a dose once and don't have to come back, where there is poverty and therefore the movement and transport are not our challenge, where the conditions for storage are easy. So that is going to be, we're going to be trying to prioritize Johnson & Johnson vaccine to those settings. And then, of course, we've got adequate numbers of, storage facilities in the urban settings. So we will then be using most of the Pfizer vaccine in the settings where there are many people within a shorter distance. So when you've got a large mass vaccination area, people can be able to come through, but that the conditions are such that nothing will affect the quality of the vaccine. This is available. These services will be available throughout the whole country, and therefore we have already started seeing how everyone is looking at their own communities to say, maybe here we'll put Johnson & Johnson, and then in this area we are fine with the Pfizer vaccine. So that will be the approach. We said we've got 51 million doses. They're actually equal to just about 42 million people. We are also still procuring a few other doses because we think that it's important that as we move towards the tail end, we're going to have to do quite a lot of mop-up to make sure that there might be people who might not have been properly accounted, might be undocumented migrants, there might be people who might have been missed out, and so on. So we are going to then look at what ultimately it's going to take for us to do to achieve population immunity at that point. Let me leave it at that now and say thank you very much for your interest, and thanks to all fellow South Africans for your patience. And we will try and give more updates as we roll out the plan. Thank you very much.
Thank you very much, Minister, for that comprehensive brief. And Premier, colleagues, it will be your turn to say who you are and where you come from, and then we can shoot. Reminder number 1, number 2, number 3, number 4. number 5, 6, 7, and 8. So finish with 8. So let's take that first set of questions.
It's Naeto from Power News, Power FM. I just need clarity. So we're receiving 51 million doses, but it equates to 42 million people because the Pfizer vaccine is administered twice. Is that correct? Just for clarity's sake.
That is correct. Separated. 31.5 million. We've got 0.5 now. We've got 31 on the contract. That 31.5 million people will be vaccinated with one jab. Then we've got that's Johnson & Johnson. Then we've got 20 million that comes from Pfizer that will vaccinate 10 people. So it's 31 plus 10. Now we've got 1.2 that's coming from COVAX. That still sends us some more. Takes us to just beyond 42 million. That's what it's going to be like. When all the other doses are available, will indicate what that will do. But that gives you a sense. But it's much more important to have enough doses for what we targeted. Something's going to arise now. That's going to force us to be able to move on and deal with others. We must be ready for that.
Lawal from Channel TV Lagos. Honorable Minister, yesterday there was a courtroom online prescription of ivermectin for COVID-19 treatment. Do you have any worries about this? Given that SAPRA gave just a cautious approval.
What is the question?
Yesterday there was a court ruling allowing the prescription of ivermectin for COVID-19 treatment. Do you have any worries about that? Because SAPRA just gave a cautious approval to that medication.
No, I don't have any worry about it. I think we need to understand that this is a new era. So there are new medication that becomes available, and therefore it still has to go through rigorous processes of verifications of safety, efficacy, and suitability for the public. SAPRA is not an agent that blocks people from getting medicine. It's an agency that checks the safety of medication to protect the public. So it is important that SAPRA must satisfy itself, whereas everyone else can go out and say this drug, that drug can be used. But SAPRA has to actually go by scientific evidence based on findings and records that they can stand to say to us we are safe when we take that particular drug. But sometimes what SAPRA would have to do is to say if there is some indication that the drug may be useful, the doctor in charge must take responsibility. So you get the doctor getting authority to utilize the drug on their own sense of responsibility as a doctor, so that they can then take responsibility. Whereas if a drug is certified as safe, and yet there are still questions about it, you can actually say the government has misled you because this is a state agency. So we'll welcome any progress in the resolution of the issue of ivermectin, so that whereas more and more evidence is made available and that it is safe and people can use it, then it must be clear what needs to be done. We have actually said this matter needs to be allowed to be processed in the way all the medication get processed, so that the safety of our citizens are assured and that the access to medication is guided by the fact that certain safety principles have been complied with. Thank you.
Legal registration portal that has been out there in the public, and your department has already rejected it as for its registration. It's registration for the second phase. So people are being asked. It's got all the clinics in the country. It's got so many details about the second phase of the program. So a lot of people have fallen prey and started registering on the registration portal. It's branded like your department, but unfortunately, your department has already released a statement saying it's wrong. What is being done now by your department to ensure, one, that it's investigated by law enforcement, two, that it's shut down because it's still active and people are falling prey? It looks legit. I can show you the link afterwards.
Now, you know, one of the work streams in the Interministerial Committee is to deal precisely with this issue. We were surprised when we started talking about vaccines. The number of companies that were registered to deliver COVID vaccines or vaccination and so on was huge. The police are actually watching that space. They have actually gone around to investigate what's going on with all of those. The police have been already on the alert. They actually found the fraudulent vaccine, the fake vaccine, even before we thought they would have landed here. So our law enforcement agencies are pretty much awake on this matter. Now that you raise this matter, each time we pick up, even as we pick up fake news or an advert, people just send us the stuff and we get alerted. So the team goes out to deal with that. We will actually follow up how far they would have gone with it. But as far as we would be concerned, anything that gets reported that is showing a misleading information to the public about availability of the service by unauthorized individuals will actually have the law enforcement agencies acting on it.
Thank you very much, Graf. It will be you. Let's make it a bit quicker, colleagues. This is a dining hall, so the owners want to eat.
Minister, this is Calvin from ENCA. I'd just like to check. How much is the Pfizer vaccine costing us per dose? And then you mentioned, I'm not sure whether you would correct in your statement on mentioning how many vaccines per day you would want to achieve towards the tail end of the rollout. Is it 250 to 270, or you mean 1,000 and per day vaccines you would like to achieve? And then I'd like to know, sir, in terms of how many phases are there? At which point do you believe you would have reached the goal in terms of the date by 2022? And then towards the tail end, you spoke about a mopping up process that you procured extra vaccines for, and you said if you find undocumented migrants. I'd just like you to elaborate on what you mean by that.
No, basically, let me put it this way. The exact amount, once I will only give you the figure. If you might have heard me say there had to be a discussion about what is the exchange rate and all of that. So once that is closed, I can look at those figures and can talk about them. Then you raise a question about how many vaccines per day. Look, I'm saying that we're going to be incrementally opening up sites, increasing their numbers, because we want to ultimately get to a point where at the peak we're able to get up to 250 to 270,000 per day. So that's when we're really rolling and pushing everyone into vaccination. You want to achieve that in the first few months. It will be something that we'll achieve later on when the sites most sites have been opened and the flow of vaccine is no longer a delay. There are 3 phases. The first phase is 3 months, and it started on the 17th of February. It will end on the 17th of May. We were wanting to try and move it quicker than that, but nevertheless, we still have that as our target. And the reason why it was 3 months for health workers was because we anticipated the delay in the supply of vaccine. The second phase will take from after the 17th of May to the 17th of October. That period is 6 months. It's focusing largely on people who are most vulnerable. We have indicated the aged, the comorbidities, people in the frontline settings, etc. So those are the ones that we need to actually focus on there. And that will take us 6 months. And it's 6 months as well because we're going to be opening sequentially some of the vaccine sites, and we'll also be looking at the flow of vaccines that you see the problem with the Pfizer vaccine is that if you did 5 million people, the next 5 million doses must go to the same people. So that's what holds you down. And that challenge is something that I was discussing with our team. The original research indicated that you need to do the first dose after 3 weeks. And then another study said up to 6 weeks you're still fine. But when we were discussing with the experts in the United Kingdom, they said they actually gave 3 months because they wanted to reach as many people as possible to get the first dose to start building up the immunity, which builds up in about 2 weeks. And therefore, it's better to have some immunity for some people than to have no immunity for many people. Yeah. So that's the issue that we're going to have to deal with. And so the point we're making is that those phases are 3 now. The third phase will be coming around what you call October, beyond October 17th, and it's going to be going that way. That now is going to be the high pressure time when we're trying to get as many people out as possible. That's when we will also be having the largest supply of vaccines, and so that's when we're going to be focusing. I'm then raising the issue of when you do so, you then go all out. You might find that there are people who may not have been registered because they didn't have IDs. You now need to make sure that all of those issues are taken into account. So there may be areas, villages where people might not have been reached. You must now go and find them and make sure that there's a mop-up. There might be people who could have got the vaccine first dose, forgot, now are worried they want to come back. You must now take care of all of that. That's what I mean by mopping up.
Okay.
Minister, I just want to ask about the proposed vaccine passport concept. Will South Africa support it?
We are investigating that matter. We have seen that that's something that's been adopted in Kenya. We've been a couple of people have come to us to show us some concept around the vaccine passport. In fact, the Africa Center for Disease Control has already approached us to show us what they are doing, and we've got a team that's working on it. And once we've got the matter investigated and concluded, we will then share it with the public.
Hi, Minister Makhura, from So is there a sense then, Minister, from some of the provinces that you're seeing this, how many perhaps vaccination sites will each province have? And also, I mean, there's a report that we're reading from Newsweek that says that South Africa is getting about 45 million grant from the US government. Please elaborate on that for us, thanks.
Well, thank you very much. We will announce all the sites. I've said we're cleaning all of that up. We know for a fact how many, and I've said that we've readjusted the numbers. So once that has been done and all the consultations, we will announce all of that because these will be specific sites. You'll go there and so on. Although they won't open at the same time, so that will be announced. The issue that relates to the grant from the US, this is an issue that is support that's going to help a number of partners who will be able to play a role in supporting the vaccination program. Some of them will be out there talking to people about vaccination awareness, and others will also be supporting on the processes that relate to the training and other issues that relate to setting up any sites where we might be needing NGO participation, particularly where the NGOs we might be saying there's a particular area where we want some targeting. So, for example, if I give an example and say we've got sites everywhere, but we want a mobile unit that's going to go up and mop up certain areas where there are, we can't lay out additional resources to cover. But you've been to this area. There are so many people there. There are so many who are vulnerable, and we couldn't reach because of transport, because of long distance. Send them there. Those are the kinds of things that we're going to be discussing with them. But we do appreciate the support.
My question relates to the Identity Fund. I would just like to know, has the Identity Fund been established as required by Johnson & Johnson, and if so, what is the financial worth of this fund?
What fund are you asking?
The fund for the people who, let's say, have issues with the vaccine afterwards.
Of course, that's fine. Yes, we call that a no-fault compensation fund. It's actually a very interesting concept. It's a concept that basically says that anyone who might suffer harm, adverse effects following immunization, needs to report, and if there is an indication of damage, how to that such a person gets compensated. So it's a protection to South Africans, which we accept as the government, that we should make that available, so that all the people who could have gone through vaccination have a place where they can go to actually report. And it's going to have a team that will receive the complaints that will be made known to the public as soon as that is done. Secondly, it will have a team of specialists that will evaluate whether in fact the injury is real, and if it is real, that it is linked to the vaccine, and it is linked to the vaccine that the government had actually procured. It's important to also say that, because we can't get people distributing fake vaccine and then they come and claim from this fund. We're not going to do that. If it needs to be linked to the fact that that's why we're procuring, and it's going to be distributed to industries, to private sector, because we know that it's safe for our people. Then there has to be a judge, maybe a retired judge in charge, so that the matter can be concluded. What it must have is an ease of access, so that people don't need to get a lawyer to get there. It must be easy. You fill in your form, you go in there, you get assessed, and so on. It must also be easy to get compensation, so you don't need to tussle about it. So there must be a way of saying, if you have got this type of challenge, this is the kind of compensation. The only thing that would remain for lawyers and courts is when somebody doesn't agree with the ruling, and therefore there's a review process, which makes it much easier, because most of the people would have been covered and protected. Of course, what the manufacturing companies are wanting to do is to make sure that they themselves are protected against it. But we believe it's a good approach. In fact, as far as we are concerned, this is the kind of no-fault compensation fund that we need to build and grow for the rest of the medical legal cases that we face in the country. Whether it's public or private, it is unfair to expose the doctor to a litigation that suggests that he went there and willfully caused the damage, when in fact we know that in the process of clinical management something can go wrong. Someone may not be ultimately be receiving the necessary assistance. They should actually be protected, but in the protection it should not be a racketeering scheme where now you get the exploitation of government in the way it is happening. So we need a balance there. The worth is not established yet. We're going through the figures, so we will announce that at the time when it's ready.
Thank you very much. Let's have the last question. Yes, sir.
Yes, simple for you. Minister, I'm able to tell how much that was paid from the Serum Institute of India to South Africa?
How much?
How much is the one that we paid back to?
Okay, I don't have the number here. Let me find it, and then when I've got it, I'll have to give it to you.
Okay. Thank you so much for another chance. I'd just like to say at the last Gauteng briefing, the medical advisory team said that there was one case of side effects that was under investigation by SAPRA. I'd just like to know if that investigation has been completed after getting the vaccines. And then will you be allowing private industries to procure SAPRA-approved vaccines and administer them en masse to the employees, such as the mining sector?
I've been made aware of some of the investigations of people who might have reported any adverse effects. On the one that I've received so far, it does appear that the ailment was incidental to the vaccination, that there was no cause. It was not caused by the vaccine. As investigations happen, we will be updated. But we have not come across a situation where one individual suffered as a result of the vaccine to an extent that there would have been a serious threat to life. All the vaccine that we have will be available for the public and private sector, and we have a team that's going to be working together so that there will be a distribution of the vaccine for both public and private. And so all the private sector, we have agreed they will get the vaccines from what we're procuring. So when we say 51 million vaccines, private sector is going to be getting from the same ones. And we would like to encourage everyone to follow that route, because once you do so, we know for a fact that there's the safety of those vaccines is assured. We also know that the safety of the patients who will receive the vaccine will be covered by our fund.
Thank you very much, colleagues. Thank you very much, Minister.
Thank you.
Minister and the acting mayor. Colleagues, that's a wrap. Thank you very much for spending the day with us.
Dr. Zweli Mkhize there, accompanied, of course, by David Makhura, the Premier of Gauteng, just finishing addressing some questions, giving answers there after a briefing there in Soweto as is going up and about in Gauteng this morning, checking out how various vaccination facilities are doing. And I mean, the big announcement is that the country has secured a total of 51 million doses of the COVID-19 vaccine, 31 million from Johnson & Johnson, and that's the single dose one, and 20 million from Pfizer, and that will be vaccinating, of course, 10 million people, because the Pfizer COVID-19 vaccine takes 2 doses. And he also said the country is expecting 1.2 million COVID-19 vaccines from the Africa's COVAX facility. So total, in all these, as they come through, will be able to vaccinate 42 million people. And 17th May is a date mentioned by the minister a short while ago as the start of phase 2 of mass vaccinations in the country.